Good afternoon, everybody. We're going to start in just a moment. Wait for a couple more people to sign on. Hopefully you can hear me. There is a chat box. If you can't hear me, I've muted everybody. So if you can't hear me, please chat in the box and let me know. Otherwise, I will assume everybody can hear me. Okay, why don't we get started, and other people might join in, and that's okay. So welcome. My name is Mia Edidin. I am the Clinical Director at Perinatal Support Washington. Today, we're going to be diving into perinatal mental health prevalence, risk, and implications within communities. So we're going to kind of dive into starting to think about that, 15 to 20% of new parents, and start thinking about what communities might be experiencing higher rates than that and why. So just a little bit about this work. This work is a pilot project that's called the Perinatal Mental Health Initiative. It's community-based perinatal mental health capacity building, and it's funded by the Department of Children, Youth, and Families, the Strengthening Families Washington program. The primary aim of the services are prevention and capacity building. It's national child abuse and neglect prevention funding. And the goal is to support community-based efforts to develop, operate, expand, and enhance initiatives, programs, and activities to prevent child abuse and neglect with an emphasis on strengthening families. I'm going to tell you more about how that looks in this program that we've developed. So we've labeled the project the Perinatal Mental Health Initiative, and it has several layers of the project. The first is we wanted to provide providers across the state with access to training in perinatal mental health. And the way that we did this was we provided two-day trainings. We provided one in Seattle in February and one in Spokane at the end of April. And those trainings were open to any provider, regardless of where they lived. And then we also offered webinars throughout this year that was also open to any providers. We did a webinar earlier this fall looking at perinatal mental health as a public health concern. I did a webinar in March looking at the efficacy of perinatal mental health support groups and how they work for pregnant and postpartum families. And then today we're looking at prevalence rates and starting to kind of look at what are the experiences of certain communities around perinatal mental health. So those trainings were open to all providers across the state. Part of this program also offered the opportunity for communities to apply for funding to do a little bit more focused work around perinatal mental health. And so there were 7 communities that received funding over this year, and part of that funding included creating local perinatal mental health task forces. That is that sort of community-based part of the work, that it was really important to create a program in which communities could come together and think about what it was that their community needed, what were the gaps in care and the barriers that families in their communities were experiencing, and what are the solutions that would work, again, specifically for those communities. And those were those task forces were head up by the local organization that applied for the funding, and they were brought together cross-sector providers to meet once every month or every 2 months to talk about what was happening in their community. And they also received perinatal mental health consultation from Perinatal Support Washington to help with the conversation of how do we address perinatal mental health needs for families in our community. Part of that work in the 7 communities was also to have a one-day training for local providers. So those trainings were in those locations so that it was easy for providers to get. And the training was completely funded by DCYF, so it was no cost to the providers. The second training that all 7 of those communities received was training in how to run a perinatal mental health support group for new families. Each community trained somewhere between 3 and 8 providers to start different groups around the county to serve different communities within the county. The support groups are really looked at as sort of low barrier, easy access points for families to get access to care. And then the last thing that those 7 communities did, and they're still working on, is creating a resource and referral guide specifically around perinatal mental health for their community. So the referral guide should be used by providers or parents and will help families and parents navigate the perinatal mental health resources that are available in the community. So things like eligibility and criteria and referral information so that providers can more easily make referrals for families, and families who pick up the resource and referral guide can navigate all the different providers and resources available to them more easily and potentially get into care faster and easier. And so the overall goals are increased community capacity. So that looked like the support groups, it looked like having more providers trained, it also looked like that resource and referral guide, and to have easy pathways for families. So trying to ease the burden on families to navigate complicated systems, and also to ease the burden on providers in navigating those systems as well to support the families they serve better. And then lastly, this is a pilot project and it's the first year of the program, and we recognize that families need high quality mental health supports, and this program did not provide really specific perinatal mental health training in terms of how to treat perinatal mental health, and we know that that's a big need of the community. This is a foundation year, and we hope to work towards trying to get more mental health trainings so that communities have more providers who know how to treat and families who are experiencing perinatal mental health complications, and we just haven't gotten to that yet. So hopefully we will continue to work towards that because we know that that's sort of the next step in creating community capacity and building community capacity. So the 7 counties that received that more focused work, Clallam County, Cowlitz County, Pierce, Skagit, Snohomish, Whatcom, and Yakima, and those are the local host organizations that applied for the funding and are sort of the point organization in each of those communities. The outcome goals to increase capacity within communities, to recognize, support, and refer families to appropriate supports for perinatal mood and anxiety disorders, and to establish and maintain easy pathways for families to be screened for perinatal mood and anxiety disorders and receive care as needed. So just a little bit about Perinatal Support Washington. We have services for families. We have a warm line. It's a parent support line that's available to families. They can call anytime. They leave a message and we call them back, usually the same day, but definitely within 24 hours. And the warm line is staffed by either parents who have recovered from a perinatal mood or anxiety disorder, so peers, and we have both moms and dads on the line, or we have therapists on the line as well. When families call into the warm line, we provide information and psychoeducation around perinatal mental health. We provide resource and referrals to trained providers across the state, and we also complete a wellness plan with them and sort of talk about all the things that they can be doing in the next week or 2 as they're accessing some of the referrals that we gave them. And then lastly, we follow up with them and ensure that they were able to access the referrals that we provided them. We support organizations around the states in leading peer and professional new parent support groups. We use a support group model called group peer support, which was developed specifically for working with perinatal families. Perinatal Support Washington doesn't own or operate our own support groups. Instead, we'd like to collaborate with local organizations to help them start support groups. And we do this by providing training in the support group model, technical assistance, and then ongoing clinical support for running the groups with new parents. We also have a statewide provider list. We have about 250 providers across the state that all have training in perinatal mental health. This list can be accessed both on our website and also by emailing or calling us. You can call the warm line number listed there or email us at info@perinatalsupport.org. There's about 85 providers listed on our website, but we have 250 more providers on our master list that you're welcome to contact us if you don't see someone in the area that you're looking. We also provide professional training and consultation, like this webinar and others. And lastly, in addition to supporting families directly, we think it's important to be looking at all the systems of care that are working, that families that we're working with are also having to work within. So looking at social policy, medical policy, statewide policy, and thinking about how are those systems and policies supporting families and contributing to their mental health, or perhaps creating barriers and causing stress for our families, and thinking about how to better serve them. So it's important to recognize, as we're diving into risk factors and prevalence, that perinatal mental health is a spectrum. So we'd like to say that it's not just depression and it's not just postpartum, that you can experience depression during pregnancy, so antenatal depression. You can experience depression after delivery, so postpartum depression. You can experience anxiety or panic at any time, OCD, bipolar disorder, post-traumatic stress disorder, and postpartum psychosis. So the prevalence rates, before I dive in there, I want to acknowledge that there is very limited research that breaks down prevalence and incidence and experiences by race or by socioeconomic status. We have some data that gives us idea of kind of what the prevalence rates might be, but some of these are not very set, and you'll see that there's a broad range on this slide, and I'm gonna tell you a little bit more about that. So in general, we estimate that 1 out of 9 to 10 middle or upper income women might experience a PMAD. So PMAD is short for perinatal mood and anxiety disorders, and I'll be using that throughout this webinar. We estimate about 1 out of 3 to 4 women who are living in poverty will experience a PMAD. We estimate that 1 out of 3 women of color are experiencing a PMAD. We want to acknowledge that women living in poverty is not a homogeneous group, that women of color are not a homogeneous group. And so these statistics are still fairly broad, and we'll get into more specific statistics, but again, communities of people are not all the same and could be having a wide range of experiences within those communities. So for instance, Latinas living in the US, there's a pretty broad range of what we know that they might experience, somewhere between 11% and 50%. We can start to pull out why that range might be different. It's not necessarily that one study says this and another study says that. It's more thinking about the many different communities within the Latina community. So thinking about recent immigrants versus people who have been in the States, thinking about people who are documented versus undocumented, geography, where they live in the United States, socioeconomic level, education status. So all of those things is going to create a wide range of prevalence rates based on who that person is and what their current lived experience is. And we're going to talk a lot more about that. So again, for African American women, we have this really broad range, 7 to 38%. And that's for very similar differences amongst the African American women, that are out there. And there's a broad range, again, of socioeconomic statuses, of education, of geography, of access to care. We do know that both Latina and African American women are less likely to report symptoms of PMADs due to stigma and fear, and less likely to be diagnosed due to variation in expression, presentation, and reporting of PMAD. And so this brings up that issue of, do we know what perinatal mood and anxiety disorders might look like in different communities? Or are we using a fairly white-centric model of how depression and anxiety might actually show up, and we're missing it because that's not how it might be expressed amongst different communities and different people? And we're going to be talking a little bit more about that in this presentation. So, understanding the causes. I think that there is a lot of misinformation around what causes perinatal mood and anxiety disorders. I hear from parents every day that refer to postpartum depression as the hormones. And there certainly is a pathway for someone to develop postpartum depression or anxiety because of the change in their hormones. So we know that at the end of pregnancy, during birth, and right after birth, there is a huge change in hormone levels. It goes from the highest hormone level that a woman will ever experience to some of the lowest that she'll ever experience within 24 to 48 hours. And there are certainly some women that will be extremely sensitive to this hormone fluctuation. And we're going to talk a little bit more about that. But that's a small percentage of women. And what we know that it's actually like a complex kind of interwoven, kind of interconnected experience of biological risk factors, psychological risk factors, social and environmental risk factors, spiritual, existential crisis, and the cultural myths of motherhood, that it's sort of a unique kind of overlapping of all of these experiences that actually put some women at far greater risk than others. And that what happens is that one stressor in any one of these areas impacts all of the other areas, creating sort of a loop of impact throughout different areas of this person's life in terms of emotional health, medical health, and birth outcomes. And we're going to talk a lot about that in just a moment. So understanding the risk factors. So we know that biological factors and social factors create intertwined rings that makes women more prone to postpartum depression by affecting each other. So it's a bi-directional mechanism. It's not, biological factors contribute to social factors, contribute to, something else, but that's actually like a loop that one impacts the other, which then continues impacting the other. And that environmental factors such as socioeconomic factors cause crisis conditions and postpartum depression through influencing the mental health during pregnancy. So that socioeconomic factors have an enormous impact on perinatal mental health and also maternal and child health as well, and that all of those things impact each other. So what are those risk factors? These are the risk factors that we often talk about. You'll hear these in every single perinatal mental health overview. Things like a prior history increases the risk of having depression or postpartum depression during the next pregnancy or postpartum period. A family history increases the risk. History of hormonal mood disorders, that was that biological component that I was just talking about. We would know this by having a history of things like PMS or premenstrual dysphoric disorder, PMDD, or having had reactions to hormonal birth control in the past. We know that risks around having unresolved losses, especially reproductive in nature, can increase a woman developing perinatal mood and anxiety disorders. Endocrine dysfunction, so thyroid, diabetes, gestational diabetes have a high risk factor. Certain personality characteristics, such as being perfectionist, being very task-oriented, or being inflexible, can predispose someone to experiencing depression or anxiety. And then there's sort of all the things that could potentially happen that are sort of during the conception period, the pregnancy, the birth, and then the immediate postpartum. So things like any type of complications during pregnancy, having a traumatic or disappointing childbirth, having a medical complication during the pregnancy or the birth that can cause medical complications in the infant. That can include spending time in the NICU, and then also ongoing developmental or medical complications of the infant. Multiple births, having twins or more, that's related to pregnancy complications, birth complications, and then also the health and well-being of the infants in the beginning, but then also the constant and demanding nature of taking care of two infants at the same time. We know that breastfeeding difficulties can be a risk factor, and that breastfeeding can be protective of postpartum depression when breastfeeding is going well, but we also know that breastfeeding difficulties actually becomes a risk factor for postpartum depression, and that women who are not having breastfeeding complications and breastfeeding is going well can still develop postpartum depression and anxiety. And then there's the things after having our kiddos and after the birth and the postpartum period, around general, how does this baby, what is this baby's needs, and can I keep up with the level of need that this baby has? So for instance, having a colicky baby, a high needs baby, having general temperament differences, any illness or injury to that infant that requires mom to take extra care, more appointments, worry and anxiety, and then developmental delays again, which cause worry, anxiety, can often take more time for mom to meet with early intervention to help their kiddos meet developmental milestones, and can just put her at risk for depression or anxiety. And then there's the social factors. And we talk about these oftentimes when we're talking about the risks for PMADs, but we often talk about them in sort of flat ways that don't really sort of help us understand why these social factors might actually impact women's mental health during this period. You know, so these social factors, recent stresses, you know, pregnancy and early postpartum is not a time for big changes because you're already managing a really big life change, in addition to managing sort of the physiological changes and recovery during pregnancy, but then birth and then postpartum, of course. We know that age is a risk factor, so teen and young mothers have higher risk. Isolation and poor social support system, this is a really big one. We're going to talk a lot about this. Financial stress is a risk factor. Having high conflict or unsupportive partners, or having an unwanted pregnancy. So a lot of these things make sense in some ways that they would be risk factors because they're challenging and stressful things that are happening. And so, but how does that mechanism sort of actually work? And what are we missing? What are we not talking about on these kind of like common list of risk factors? And what we're not really talking about, and why we know that some women have a much higher prevalence around experiencing postpartum depression or anxiety, is we're not really talking about what chronic or intergenerational poverty looks like, especially during this childbearing period. We're not really talking about intergenerational trauma. We're not talking about racism or oppression, and how these things, when we talk about that sort of layered kind of, impact of both the social factors, the biology, and the psychological factors, like these have tremendous impacts on a new parent's emotional well-being. And obviously they have negative impact on mom's emotional well-being, and they really cannot be separated from thinking about what's happening for her and the risks that she might have to having a negative response to these during an especially vulnerable time for her and her infant. So women don't become mothers in a vacuum. They live in families, extended families, cultures, and societies. At each of these levels of social connection, mothers can be protected from or made more vulnerable to depression. The social factors related to depression include the amount of help she has with her baby and other children, the amount of emotional support she receives from her partner and others around her, her socioeconomic status, and her exposure to stressful life events. A quote by Kathleen Kendall Tackett. Her website, Uppity Science Chick, has a wealth of information around perinatal mental health and well-being. So again, it brings us back to this idea of this complex and layered risk matrix. The biopsychosocial approach, is like a word that we talk about all the time, but it's something that I think we really need to spend some time thinking about, and how these different areas really actually impact women during the perinatal period. So this is sort of the general biopsychosocial model. But here's what it looks like when we actually start looking at it during the perinatal period. So this is actually for part of a study, or I'm sorry, not a study, an article that they were looking at a complex case. So some of this is more specific, but this is in general how we might look at the biopsychosocial model during the perinatal period. So we would look at those socio-demographic factors, like how old is the person, are they partnered or married, what is their education level, what is their employment and or income level, what is their immigration status, what does their support system look like, are they experiencing interpersonal violence now, or do they have a history of it, are their partners currently using, are they currently using now, or the history of that. And these areas kind of help us see sort of what we might look for when we're working with a pregnant person, to really think about all these different risk areas that we might want to evaluate and really think about, but also help us really understand why someone in this period might experience more likelihood to experience depression or anxiety. I'm just going to move this so I can see. So obstetric factors, we're going to be looking at things like, was the pregnancy intended or wanted? What hypermesis is a extreme form of morning sickness that lasts throughout the pregnancy. It has high correlation with depression or anxiety. What is her experience around perinatal loss or previous pregnancy loss? Preeclampsia, premature delivery. So these are examples of all the things that we're going to be looking for during her pregnancy, birth, and postpartum, to see how they might be impacting her mental health. Psychological factors at the bottom right there. Is she experiencing anxiety or depression? Is there a history of depression or bipolar? What's the family loading? Meaning, like, what is the family structure around her and how is it impacting her? Stressful life events during pregnancy, relationship issues with partner, poor emotional support, financial difficulties, and then the like physical and biological factors on the bottom left there, sort of looking at sort of what are some of the biological experiences or any of the deficiencies that might be causing anything that could actually look like mental health. You know, so anemia, for instance, can actually cause and also look like depression. Same with vitamin B12 deficiency, same with vitamin D. So some of these things can both mimic and or cause mental health disorders. So my slide's just being a little slow to move forward. It'll go in 1 second. Maybe. Sorry, I'm just having my hard time going to the next slide, so I'm going to troubleshoot that for 1 moment. Okay, there it goes. So of those risk factors, poverty is one of the highest predictors for postpartum depression. So we know that poor mothers face daily stress around uncertain income, dangerous housing or neighborhoods, negative effects of being at the bottom of the social strata. So in addition to having these daily stresses, the perinatal period is a time of these stresses actually worsening, because perhaps she can't work as much as she did before because of anything related to the pregnancy, any medical complications that she's having, just energy and stamina. And then also after the infant is born, we know that children with young mothers in the home, so prior to school age, is actually a time when families have the least amount of income, and so it has the highest financial stress and burden than at any other time in the child's life. We also know that the first 3 to 5 years is a very important time in a child's development. And so what we're seeing is an interlay of both increase in stress that was already there, but an increase of stress for mom at a time when the infant actually needs her to be the least stressed as possible. And so We're going to talk more about kind of what that looks like for some communities and some of the intergenerational the intergenerational transmission of trauma and ACEs. We know that poor women are more likely to be exposed to trauma, and we know that poverty increases the difficulties new mothers experience because at the time that she might need the most help, she has the least access to support, access to medical or mental health care, or access to community resources due to the increased stress on her time and her ability to get around. Again, if we're thinking about potentially having any type of pregnancy complications, you know, it can be a time that's incredibly difficult to both keep up with work, the other children in the home, access mental health care, and then access services that can actually be pretty difficult to navigate. So how do you find access to care at a time when you have the least time or the least resources to access it? So women with excuse me, a low monthly income, less than a college education, who are unmarried, or who are unemployed are 11 times more likely to have postpartum depression. If we're looking at Washington specifically, this data is from 2014, so it's just a touch old, but it was the most kind of compiled data I could find. So poverty by race in Washington. So we know that single women with children in the home are living, 40% of those families are living in poverty, and overall 22% of children in Washington state, 0 to 4, live in poverty. And just want to note that these rates are based on the federal poverty rate, which is around $23,000, but this is not representative of the cost of living in Washington state. And so these would be considered extremely poor families. And then on the right there, that chart is a breakdown by race. So American Indian, Alaskan Native is showing around 30%, Hispanic 22%, give or take, Black 22%, Native Hawaiian and Pacific Islander is showing, you know, around 18%, Asian 12%, white maybe 11%. So if we're looking at trauma, we know that trauma is also a strong predictor of depression during pregnancy. We know that trauma and depression have significant impact on pregnancy outcomes. And that's one of the pathways that increases health disparities for mothers and infants. We're going to talk a lot about health disparities in a moment. But we know that pregnancy complications, so that's maternal and infant health disparities, is also correlated with higher rates of postpartum depression. One of the things that I think is really important is I think that we're becoming more familiar with the idea of maternal and infant health disparities for certain communities, specifically communities of color. But what I think that we're not doing a great job of talking about is we often are framing those as medical experiences. And what I really want to talk a lot about today is that those might be medical experiences, but they have very significant emotional health implications. And that these medical experiences are actually traumatic experiences that are happening during the perinatal period, which is putting vulnerable populations at more risk for developing something like postpartum depression or anxiety, which then further impacts that system, that mother and infant system, that infant that is needing that mom in those early years for their development, and then actually creating an intergenerational transmission of poverty as well as emotional health complications. So we know that women with post-traumatic stress disorder showed greater bonding impairment and parenting difficulties, and that, you know, when we're talking about trauma, you know, racism and oppression are trauma. That's what those are. So if we're talking about how a person might experience racism and oppression, we internalize it as trauma, and it can show up as either PTSD, anxiety, or depression. So if we're looking at Black, Indigenous, and women of color, we know that they're significantly more likely to experience trauma. They have more lifetime post-traumatic stress disorder and trauma exposure. Black women were 4 times more likely to have PTSD than other women, and this did not vary by socioeconomic status. It was explained by greater trauma exposure. that maternal and health disparities caused by racism cause Black mothers to die at 3 to 4 times the rate of white mothers, and then Indigenous mothers die at 4.5 times the rate of white mothers. Experiences with trauma leave mothers vulnerable to systems of depression or anxiety, and then I would say that further stresses and taxes the whole system, her whole family system, including her community, and we're going to talk more about that. We know that trauma impacts infant health disparities, so those things include things like preterm birth, infant death, health complications of infant, and then developmental impacts on infant. Black and Indigenous infants are nearly twice as likely to die by their first birthday from congenital malformations, sudden infant death syndrome, and prematurity. American Indian and Alaska Native was the only racial or ethnic group that did not experience a decline in infant mortality. And that maternal and infant health disparities equals trauma for the mother, the infant, the family, and communities. So again, you know, when we say that word maternal and infant health disparities, what does that really mean, right? That means, you know, some of the worst experiences that you could possibly imagine happening when you're pregnant or when you're giving birth or in that first year after having your infant. It's the list of things that nobody wants to happen. And what happens is we often talk about these as though they're a medical experience that needs to be solved by the medical system. And what we know is that if we're looking at this biopsychosocial model, if we're looking at this complex kind of interconnectedness of all of these, you know, poverty, so, social structures, the psychological histories and current psychological experience of the parent, and then all the biological stuff that comes along with pregnancy, that these things are completely interconnected, and that it's not a medical intervention that's needed or a mental health intervention that's needed, but something that addresses both of those things, and not one of those things. This is just a really great infographic that was not created by Siobhan Odom, but originally used it in a presentation around perinatal mental health for women of color at the Trauma and Birth Conference in Seattle. I want to give her credit for introducing me to this infographic. But this infographic, I think, can really help us see sort of the intergenerational transmission of trauma. So a caregiver with a traumatic experience, she experiences, we're at the top there, the top left, the mother is experiencing stress and trauma, her cortisol levels increase, the baby in utero absorbs that cortisol, which is basically like high stress is when we release cortisol. It can impact the baby's development in utero. In general, the caregiver struggles to regulate her emotional experience. She can actually have difficulty with her caregiver relationships and with her children due to attachment difficulties. And then the child can actually have impacts in terms of who they develop, who their sense of self is, their ability to integrate their own experiences, and the beginning of the epigenetic expressions of the adult's trauma within the infant. Then that infant grows up. So that's a person who's had a caregiver who had untreated trauma. They might be more likely to experience PTSD after trauma. They might be more likely to struggle to repair conflict. They might struggle with relationships. They might unintentionally bring out negative behaviors in others, be emotionally attached, be more prone to dissociate. I think one of the things that's really fascinating about this work, and it's some of the work that Nancy Grote has done at UW in terms of studying using interpersonal psychotherapy with pregnant and postpartum moms around postpartum depression, is how adults kind of in this middle range here who are some of those things that I just listed, struggle to repair after conflict, struggling with relationships, unintentionally brings out negative behaviors in others, how these characteristics can show up in the provider and the parent interaction. So the OB, the mental health provider, the public health nurse. And when I'm working with providers who are working with new parents, I'm often hearing from them things like difficult client scenarios, or sort of they can describe parents in maybe negative or judgmental ways. And I often go back to this idea of, adults have learned how to interact with their medical caregivers in ways that are representative of their attachment experiences when they were young. And when we look at sort of how intergenerational trauma and ACEs and attachment impacts adult women's ability to receive care, kind of this is the crux of it right here, that the systems that are treating women certainly need to be adjusted to make sure that they're more culturally appropriate, to make sure that they're, you know, provided in the language of the mom, that take into account sort of all the barriers that parents experience in accessing services. And they need to take into account this, what does this intergenerational trauma look like? How is it showing up in our treatment rooms? And be really speaking to that in terms of how we're providing care for our mom and engaging moms in the services that we're trying to provide them. And we're going to talk just a little bit more about this. Oops, so every time I sit on a slide for a moment, my computer then gets slow to adjust to the next slide. So just give me 1 second while my computer moves on to the next slide. There we go. So the impact of poverty and trauma on perinatal mental health. So we know that low-income women experience postpartum depression at the highest rates. Women of color, twice the rate of white women. Poor treatment by providers due to bias. So women report 27+% women of color with low socioeconomic status reported mistreatment by providers during their birth. Almost 19% of white women with low socioeconomic status reported the same thing. We know that in general, we have lower treatment initiation by women of color, lower treatment retention. There's reports of mistrust of providers and systems that have been traumatizing to families historically and presently, and that maternal and infant health disparities equals further traumatization during the perinatal period, which further impacts a woman's mental health, in addition to all the things that I've kind of already talked about. The social and emotional impact on children. So children of mother with PMEDs have higher risk of behavioral and developmental disorders themselves, including attention deficit hyperactivity disorder, depression and anxiety, behavioral or conduct disorders such as oppositional defiant disorder. Children of color are more likely to be disciplined in school, be expelled or suspended, be involved in the juvenile justice system. Impacts on children as adults. They might experience mental health disorders. This is that intergenerational transmission piece. So I think that it's important to look at these impacts. I'm going to go back one, and then go back to this one, to look at these impacts, not just as these are all the bad things that happen, but that all of these things that happen create the situation in which women have more and more to do, more to worry about, more appointments to go to, more things to navigate, more interactions with systems and providers, and that it sort of creates this kind of this buildup, this layer of risk factors that largely women are dealing with. We know that dads obviously have their own experiences during this time, but a lot of these things fall to women. And so then there's this economic impact. So if we know that trauma and poverty and racism and oppression can look like depression, or can become or turn into depression or anxiety, we also know that the depression or anxiety impacts the mom's pregnancy and can look and can cause things like preterm delivery, higher rates of cesarean delivery, which then for that mom on the ground looks like recovery from a birth that was much more difficult than recovering from a vaginal birth. There could be complications from the delivery, or they might have delivered a premature infant, which takes time and energy and resources from that mother. So things like thinking about who's taking care of the other infants if there's a premature infant in the NICU, things like navigating, taking care of other kids in the household, while the kid is in the NICU or home and returns home from work. Can mom take off from work if her infant is in the NICU, or if her infant has medical needs that prevents her from being able to put them into childcare. So these are sort of the realities in the postpartum period. for women who are having these experiences. So then we have the productivity loss. So there's something called presenteeism. So mothers might be less productive when they're at work. They might be more likely to make mistakes. We could extrapolate from this, how this might impact her relationship with her boss, her relationship with, any of the coworkers, whether she might be, given the opportunity for a promotion, or even just the standard raise, that she might be likely to get or not likely to get because of how her performance is being judged at work. She also might just miss work, right? So she might, due to her own mental health, due to her infant's needs, if they have a medical complication, she might not be able to attend work as often. And then she might either not be able to continue to go to work at all and might become unemployed, or might lose her job because of these stresses that are pulling her away from being, 100% present at work all the time, and only being a worker, and not being a parent and a worker and a person having all of these experiences. So we know that women of color and communities of color are then disproportionately impacted by mental health complications that then cause medical complications, which then cause more mental health complications. And I hope you guys are seeing this sort of cycle that's being created. This is a really interesting conceptual model of untreated PMADs. It was by a study through Mathematica that just came out, and it really outlines this idea of what are the sort of like all the different ways that families are impacted, and society or communities are impacted by perinatal mental health. So untreated perinatal mental health, for the mother, I've talked about some of these things. You have higher work and absenteeism, and that presenteeism, that, not being fully present at work. How, can she participate in the labor force? In what way? Her own mental health worsening, and the potential of her experiencing suicide ideation, or perhaps even experiencing suicidal feelings. Increased risk of worsening mental health, or worsening health in general. So again, obstetric and mental health, and that kind of interrelation between mental health and obstetrical health. So all of those things, if we're kind of following it over to the right, can lead to can lead to income loss and reduced economic output. Increased use of public sector services, increased use of healthcare costs. Those are across the board for the mom. And then for the child, right, we know that untreated perinatal mental health increased low birth weight and potentially preterm birth. We know it's a lower likelihood of being breastfed, increase of sudden infant death syndrome, increased risk of behavioral and developmental disorders, increased likelihood of worse child health. Injuries, asthma, fewer preventative visits, and obesity. So all of these things create a system in which that mom is navigating sort of all of these things, as is her family, her community, and then sort of the broader society. So where to go from here? I think in 2016, there's a little typo in there. It's supposed to say United States Preventative Services Task Force. There's a couple typos on there, I apologize. In 2016, the USPSTF made a recommendation that all pregnant and postpartum women be screened for depression and anxiety. And that was like a landmark. It was like very important recommendation. The USPSTF is responsible for a lot of what is deemed reimbursable by insurance companies. And there's a rating from, A to I think D, and anything that's rated as an A or a B are things that insurance companies are supposed to reimburse. When that came out, it was a really big deal. This year, however, they came out with a second recommendation. And they recommend that clinicians provide or refer pregnant and postpartum persons who are at risk of perinatal depression to counseling interventions. So this is a really big deal, because if we know about how insurance reimbursement works, is you actually need to have a diagnosable condition normally to bill insurance. And so what the USPSTF is referring and recommending is that we actually be identifying families that are at high risk of developing postpartum depression, even if they haven't developed it already, because of the significant impact that perinatal depression or anxiety has on infant development, lifetime development, and then obviously like the next generation sort of impact on the next generation of that child born to the mom of untreated perinatal mental health. So this is really significant, really important. The interventions that they cite is interpersonal psychotherapy, that's IPT, cognitive behavioral therapy, CBT, Mothers and Babies program, which is out of Northwestern, which is a really great program because you actually don't have to be a mental health provider to do it. So it's great for communities that don't have a lot of mental health resources. It can be done by a home visitor or a nurse or someone, again, who's not a mental health provider, because again, this is really preventative services. It's not mental health treatment. And ROSE is another intervention that was listed. The counseling interventions were associated with a 39 to 53% reduction in the likelihood of perinatal depression. So this is really a prevention approach. This is an upstream approach of let's not wait until moms are depressed and anxious. Let's see if we can identify who might be at high risk, which is why sort of thinking about all the things that I've just laid out today, what we know about what creates higher risk for certain women in certain communities can help us in thinking about who might we want to target services for, who might we want to ensure are getting preventative services. And what's interesting about some of the work that they cited was that the women who are at increased risk of perinatal depression based on history of depression, social or socioeconomic risk factors, they demonstrated the largest positive effect compared with women who were lower risk who also participated in those interventions, although both had positive risk reduction. So 45% risk reduction for those higher risk women and 21% risk reduction for those lower risk, which is still really great. So where to go from here? Effective and early identification, screening, and treatment options for women that are culturally appropriate and accessible, thinking about sort of all of those barriers to care. Providers across the maternal and child health field need greater awareness of the interconnectivity of economic and social reality women experience prior to and within the perinatal period. So basically how poverty is a huge indicator for postpartum depression, and providers need greater awareness and the impact of trauma and mental health throughout the perinatal period. So again, kind of addressing this piece of women are coming into the childbearing period with an enormous trauma load. They are being re-traumatized during the perinatal period. And then transmitting that trauma to their infants who are then growing up and becoming parents themselves. So there is some time for questions. I think I can unmute you all, or you can, you're welcome to ask questions in the chat box. That is my email there, of course. You're also welcome to email me any questions you have or any follow-up. Let's see. So you are unmuted. Does anybody have any questions? Great. Well, you have my email and you are welcome to follow up. This presentation will be on the Perinatal Support Washington website probably early next week, if not sometime late this week. And it'll be available as a link and can be shared easily. So thank you so much for coming today. I'm just going to check really quick to see if there's any questions in the chat box. I don't see any. Okay. Well, thank you so much for joining today, and I look forward to connecting with you all in all the other ways that we might be working together. Thank you so much.